So one of the first things we do when we're thinking about someone's airway is we do an assessment, and that's really when you can figure out how difficult of an airway this is going to be. So I'm going to go over some of the signs that we can look for in our patients when we're doing our pre-op. That's going to tell us that maybe this patient is going to be a difficult mask or a difficult intubation. Many of the signs and symptoms or risk factors for someone being a difficult airway also coincide with patients who have obstructive sleep apnea. So a history of someone who has OSA and needs a CPAP at nighttime usually is a pretty good indicator that they're going to be difficult to mask, because when they fall asleep and they're laying on their back, all of the soft tissue in the airway we know collapses and creates a very tiny passage for air to get by. Some of the other factors you could look for are an increased neck circumference greater than 42 centimeters. If somebody has a limited mouth opening, for example, if they can only open their mouth about that much, that's going to make it more difficult for us. If they have a large tongue, male gender is another one that's a risk factor. History of snoring can also tell us that they're probably at an increased risk factor for obstruction when they fall asleep. And there's another couple other things that we can look at just when we're looking at a patient. For example, there's something called the thyromental distance, which is the distance between your thyroid to the tip of the jaw. And we usually say if it's greater than 6 centimeters or about 3 finger breadths, that's pretty much a good sign for us that they're not going to be too difficult. But if it's less than that, then we're a little bit more concerned that they could be difficult. Another thing I look for in my patients is to see if they have teeth. Many of our older patients are edentulous and wear dentures, and we take those dentures out once the patient falls asleep or even before they get back to the operating room. Not having teeth has more consequences of soft tissue getting in the way of our masking. And so for those patients, I typically will put an oral airway in as soon as they fall asleep to help us mask them. Another thing that works against us are beards. Beards make it very difficult for our plastic to create a seal against the skin. And so as we're masking, there's a good chance that some of that air that we're forcing into the mouth is going to leak around the mask because of the hair around the beard. Lastly, when I'm thinking about how difficult someone's going to be to intubate, I also think about their neck mobility. So typically when we're going to intubate someone, we'll cause some flexion in the neck and also extending the neck forward this way. And that's basically get them in a sniffing position where our axes can align so that when we're looking down the mouth, we would basically almost have a straight shot down into the trachea where the vocal cords live. Now, patients who have had radiation or have had neck surgery where they have fusions typically have a limited motion how much their neck can flex, and that can make it difficult for us to actually intubate them. For patients with limited neck mobility, I usually will use a video laryngoscope because that usually gives us a better angle to visualize the vocal cords when we get in and not have to rely as much on getting into the sniffing position where we flex and extend their neck. And so that gives us an advantageous angle in ways that we can get the breathing tube into the vocal cords. Like anything we do in anesthesia, preparation is key for success. And so that starts in the pre-op area, as well as also reviewing the last time a patient had an anesthetic and if they've been intubated in the past. Now, usually if someone's had a difficult intubation in the past, it'll be well documented, and you can look at that note to see how exactly they were able to intubate that patient. And using that information, you can try and replicate their success. Now, if you don't have that information, you basically try and optimize your patient as best as you can, getting them into that sniffing position like I've been describing, optimizing their oxygenation before you put them to sleep, and also having all the equipment that you possibly might need in the room with you.